So I'm going to try to be kind of lively to keep you up. Thank you for that introduction, and I'm delighted to be able to be with you this afternoon to broaden the conversation that was just started into the world of rehab, which is my world. And I'm going to start with a clinical presentation of a future patient that some of you will see further in your career. And I promise you that no HIPAA violations will be committed in the process of telling you about this future patient. And I also mentioned I have no disclosures to make in terms of potential bias. So this patient that you will see at some point is a 34-year-old male who was a career military officer. He was experienced in major multiple trauma in theater. He resulted in quadruple amputations, severe 80% full thickness burns of the parts that were left, high spinal cord injury at the C2 level, and he was apneic as a result of that. A review of systems revealed that the only past medical condition was asthma. He was an elite military martial arts expert. He was married, had a wife who was pregnant with twins, and recently they had been having increased marital discord because of differences in political views. She was a supporter of Hillary and he was a supporter, well, no, sorry. The physical examination revealed that he had bilateral transhumeral amputations, bilateral transfemoral amputations, had no spontaneous respirations. He was on endotracheal ventilatory support. He was insensate and paralyzed below the C2 level, had burns over 80% of his body, of the residual body, including limbs, trunk, face, and scalp. The care that he received in this future scenario included his burns being healed with cloned skin, transplants. He received direct neural implant controls, prosthetic devices. He was fit with a portable ventilator that was installed in a trunk orthosis so that he returned to spontaneous respiration using this technology. And all of these technologies were supported by nanoelectrode instrumented electrodes directly to brain connection. He had electrical stimulators implants to restore bowel and bladder continence and evacuation. And by the way, he had gene therapy applied so that he became immune to any potential infections, and by the way, it eliminated any risk of cancer developing. On a functional level, he learned how to use all of this equipment and technology with physical therapy, occupational therapy, speech and language therapy. He experienced cognitive rehabilitation, and all these therapies in an intensive setting resulted in the complete restoration of all gross and fine motor abilities and complete self-care independence. His mood, however, became increasingly more morose. He became more hostile, he became more depressed, and he had a tendency to violent outbursts. His wife gave up on him after a period of time, but before the birth of his twin children, and she severed all contact with him. He was discharged. Excuse me. This leapt out of my hands. You can't take the story anymore. Because of his full functional rehabilitation, he returned to active military duty. Medically, over the subsequent years, he remained stable with all systems functioning and became even more adept with his martial arts skills, particularly swordplay. He rose to progressively high rank in the military system, eventually took over a leadership role in overseeing a counterinsurgency operation, which had quite a large scale of theater. He became progressively more socially isolated, violent, and self-absorbed, and his underlying depression over the loss of his wife and family continued to eat at him emotionally. Many years later, he had a violent confrontation with his estranged son, which resulted in his decision to voluntarily end his life by removing his own life support system and neurologically controlled orthotic systems. This is, of course, our patient. I actually saw him earlier in the presentation today. But what I want you to know is that everything I just told you is either already here as a capacity or a relatively near term. Some of it's a little further out, so maybe I'm taking a little flexible leap with reality. But the things that are going to happen in the future of rehab, and many things I'm going to share with you now are the things that are currently happening. I'm going to talk a little bit about the technologies that we are able to use today to achieve incredible functional outcomes for our patients. talk a little bit about what really drives our ability to deliver these services, which is really social, political, and economic. So I'm going to touch on all of those things and also touch on settings of care where these things can happen. So really first focusing on the technology, we have really neat technologic advances. You have a lot of great toys out there in the exhibit hall. You have a lot of fantastic technologies that you are using that were talked about throughout the day. We have tools that we use regularly now. We use musculoskeletal ultrasound to routinely diagnose and treat and use as guidance for our interventional procedures. We use functional magnetic resonance imaging as a guide towards therapeutic interventions. There are studies now that we can detect consciousness in patients who appear to be not participating in their environment. There's been some fascinating studies published in Science about patients who appeared to be completely vegetative, who had fMRI studies and were asked to visualize playing in a tennis match, and their fMRIs were identical to an able-bodied person, showing that there was in fact cognitive processing in somebody that appeared to the external world to be completely non-communicative and in vegetative state. There are studies that have been used to determine from the electroencephalographic activity to interpret intention. There have been studies that have shown how you can identify what somebody is looking at by detecting patterns in their occipital brain waves. And there's hope that a lot of surface as well as deep installed electrodes can really lead to functional use of brain activity as control sources for practical functional purposes. There are other ways to evaluate brain function. Near-infrared spectrometry is a way of just with bright light shining on the skull be able to detect increased oxygen utilization in the blood supply to the brain to help detect brain activity. And even genetics are starting to creep into our world of rehabilitation. There's a study that's being planned right now to do gene samples of every patient who receives a comprehensive inpatient rehab program, and then to look at genetic patterns that are predictors of high performance outcomes from rehab. So at some point it's feasible that we may say we'll have to do a gene profile to determine whether to admit you to our rehab unit if you have the propensity to respond well to the therapeutic intervention. So genetics will even be coming to my world of medical rehabilitation. Installation of electrodes directly onto the brain has been done in humans to control external devices. It's been done in animals as well. Deep brain stimulator implant for Parkinson's disease is a routine practice now. We have a number of neurosurgeons around the country in our rehab hospitals that we partner with to, you can basically turn off the Parkinsonian tremor by flipping a switch on the stimulator, which is to a deep brain environment. Transcranial magnetic stimulation, these are magnets. You can put high intensity magnets on the surface that can actually induce electrical current flow in the brain and stimulate brain activity. It is possible to neurally modulate brain behavior, brain function with external magnetic signals, or transcranial direct stimulation can be used. This is basically a 9-volt battery with buzzing electricity through the brain, and you can use several of these and sort of have the signals overlap, and you can stimulate very specific areas of the brain to achieve functional betterment. These technologies are actually FDA approved for treatment of dysphonia for people with an apraxia, and is actively being studied for everything from ADHD treatment to depression treatment, not the old electroconvulsive therapies that I experienced, participated in, didn't experience as a student. But we are starting to learn how to manipulate the brain for functional purposes, and that's extraordinary activity. Brain-machine interfaces are real. Here's an example of a monkey who had electrodes installed, and he doesn't know that he's controlling a robotic arm instead of his own hand, but he spontaneously figured out how to do this. And there's actually been an experiment where he was controlling an arm across the ocean so that you can transmit these signals long distance. So telehaptic, telemotor function is actually possible now. Not practical yet, but it is absolutely possible. We can augment the human body, and we do that, you see routinely now, left ventricular assist devices and full replacement devices. For some patients, these are just a temporary intervention. For others, they are the end state treatment of replacement, and some of these patients get these devices installed and can actually walk off the table practically and go out. Others really have had terrible debility and require intensive medical rehabilitation to recover from all the disuse, atrophy, and the just being in bed for so long. Prosthetics and the world of computer controls have merged in many ways. This amputee, above knee amputee, is walking downstairs foot over foot. That is impossible with a conventional prosthesis and only possible with a computer-controlled appliance. And these are now routine, expensive, but routinely available. Similarly, myoelectric upper extremity devices. The man on the left is Dean Kamen, the guy who invented the Segway and a number of other devices. He also worked with DARPA, the military development agency, to develop some highly advanced prosthetics, upper extremity prosthetics and robotics are merging together. We now have prosthetic systems that have some sensory capacity built into them, as well as much more sophisticated motor function. So replacement parts are becoming very, very realistic and feasible. Exoskeletal orthotic systems are becoming very, very commonplace in rehab hospitals. This is expensive technology that started with a military application. Imagine a suit that you can apply that will take over load, facilitate and supplement power and endurance. And so this was developed as a protocol for military applications to increase the endurance and weight-bearing capacity of soldiers. But it has been converted. There are now 4 commercially available exoskeletal technologies in the marketplace, primarily for patients with paraplegia, some with tetraplegia, and one has been FDA approved for patients with stroke, where the patient can don these devices and walk. Not the walking the way I did coming up onto the stage, but with a pair of loft-strand crutches and somebody standing close by, because the technology is still evolving. But it is very real. If you ever watch, how many of you watched the Glee, the TV show Glee? Artie, the kid in the wheelchair, at one of those episodes, he put on a pair of these devices and walked across the stage. So it's captured the public imagination, and it's very real stuff. We have functional electrical stimulation orthotic systems. This patient on the left, holding a cup, that person has a hemiplegic arm, but the electrical stimulation inside that orthosis facilitates small amounts of volitional activity and allows functional use of the hand. The patient on the right is using a myoelectric 4-quarter amputation prosthesis to be able to, just with rewired nervous system. The surgeons at Todd Kuiken and his group at the Rehab Institute of Chicago and Northwestern have rewired the residual nerves that were feeding the median and ulnar nerves in the arm, reattach them to the pectoralis muscle to create a signal source so that the electrical activity of the muscles can be picked up and used as control signals so that amputees can control devices using, again, you think about opening your hand and the prosthesis does it. So you have very little learning. You use the existing patterns, engrams of motor behavior, just you've rewired the nervous system for your convenience. Sensory substitution is coming. There is a lot of active work going on trying to create artificial sensors that can detect touch. The world of robotics is very interested in this, and again, it's another convergence of robotics technology and human needs for both prosthetics as well as orthotics. Prostheses are replacements, orthoses are add-ons to residual parts that are still there but not functioning. Respiratory function, that Darth Vader was a C2 tetraplegic. This was Terry, a child I took care of in Seattle, got me on the cover of National Enquirer newspaper. Not many physiatrists have been on the National Enquirer, but because back in the 70s, we convinced surgeons from Yale University who had developed this phrenic nerve stimulator implant technology to come out to Seattle and do the first installation on the West Coast to this 6-year-old who rolled out of bed and became a tetraplegic just from rolling out of bed. Scared the crap out of me as a parent. But some kids have unusual ligamentous laxity at the atlantoaxial level at that age, and it was a terrible situation. But this procedure, he became fully independent of a volume ventilator and fully dependent on a 9-volt battery connected to the external stimulator. There was a passive receiver and an amputee antenna and stimulator about the size of a paperback book, and we sent him home. To live with his family. He had 2 or 3 years of good functional life at home despite being a ventilator-dependent tetraplegic child, and then died at home. Tele-Rehabilitation is coming. I'm sure you guys are using telemedicine, audio-video communication. We just this week installed in-touch robotic system at our Kessler Institute to develop a better capacity to have a quick response from subspecialists and consultants for a change of medical status in our inpatients, and are developing all sorts of pathways to improve the flow of information and decision making and help you be there without being there. And eventually not only audio-video information, but also haptic, which is touch information, will be transmissible. So you'll literally be able to physically examine a patient remotely as if you were feeling that patient and touching that patient, and having the ability to then move a therapist's arm on the other end and actually manipulate. So that is coming. That's very much in the real world. One of the biggest problems we have in medicine is we're running out of people. You saw that population curve where workforces are aging out in many cases, and people don't want to work the same way that they did in my generation. So we're looking for substitutes for workers. And one of the substitutes that serious companies are looking at is robotics to replace human caregivers. This is not a guy in a suit. This is a Honda serious project to develop robots as primary. Their business strategy is to develop robots to be caregivers. And so this is an amazing technology, freestanding, that is not yet, to my knowledge, deployed in that function, but is still leading the way. Here's robotic therapy for a child, upper extremity movements. Robotic technologies allow highly repetitive data capturing activities that can be very visually and emotionally engaging. This child can think he's using a video game, playing a game, but in fact he's doing intensive, highly repetitive rehab. And what we know about improving motor skills is that it takes high repetition rates to get better. Basically, practice makes perfect. It takes 10,000 cigars to be rolled by a woman in Havana before she becomes a highly skilled cigar maker. So it's a high repetition is the way motor learning really behaves. And if you've tried to play a musical instrument, you know how long it takes to really develop your skills. Same thing with motor learning for somebody with a neurological injury is like achieving elite athletic performance, and we need to practice in that kind of a way. Robotic ambulation therapies are very exciting. This is the Locomat, a mere $470,000, and one can be yours as well. It uses overhead suspension technologies and robotic manipulations to control the legs and trunk so that patients can again experience and go through gait training and again have that high repetition experience to improve their ability to function and to walk eventually. A transfer robot. Patient handling is the biggest cause of work-related injuries for caregivers. Lifting a patient, you pull out your back. So again, the Asian market is looking at replacing human beings in those tasks with devices, and this is one effort in that regard. Preventing falls, we heard earlier about falls, fall prevention. Well, what you really want to do is, if you can't prevent the fall, you at least want to prevent injuries resulting from falls. So this is one of many different ideas for trying to anticipate whatever action the patient is engaging in or not engaging in that is going to lead to a fall, so that you can intervene at the right time. And we see all sorts of fall monitoring technologies coming into play. I mentioned, this is my view of virtual reality, Washington, D.C. Here's real virtual reality. This is the Toronto Rehab Institute, University of Toronto. This is a room, a big laboratory they dug under their building to create a gimbaled device that can have rooms installed on it. They can change out rooms. This room on the right is the replica of the streets of Toronto for patients to virtually learn how to navigate in a busy traffic environment. They can take this room off the gimbal with a crane and put on a winter environment room and test the anti-skid capacity of snowshoes, which is a real project they did for a commercial enterprise, going up or down icy stairs. And I just lost my mic. Or else I just went deaf. I'm not sure which is which. Anybody care? Guys? Okay, I don't know if the audience on the internet can hear, but I'll keep going a little bit louder. So augmented reality, Augmented reality is the next approach. And if you have an iPhone for sure, and probably an Android, and you have the application Yelp, you have augmented reality on your cell phone right now. There's a monocle function on your Yelp app, which basically will allow you to point your phone at a city street, and you'll see the city street, and Yelp app will superimpose on that data about the buildings that you're looking at, and so you can see information. A medical application is, imagine having a detailed image through CT scanning of the thoracic cage, and then superimposing that through your Google glasses so that you can see inside the body while you're actually examining somebody. So the merge of digital information with visual analog information is very real and moving forward. On the social political front, the rehab docs are in short supply. It's hard for me to find them to work in an inpatient rehab setting, but it's actually getting a little bit easier because of the technologies and the exciting things we're able to do for patients with spinal cord injuries, brain injuries, amputations, strokes, the kinds of trauma, people that keep surviving and helping to get into our hands. And we're figuring out ways to do things. Everybody's trying to increase their sophistication professionally. We all do it. When I finished my residency, there was no such thing as fellowship training in PM&R. Now every one of my residents goes into fellowship experience. All of my therapists started as bachelor's prepared individuals. Now it's a doctoral level preparation for almost all of our disciplines, and everybody's rising. So it just creates more people who want to function at an executive level, and there are fewer hands to actually put on the patient and take care of things. So we keep looking for substitutes for the human beings that are doing different things. Sadly, war has been very good for rehab. World War I and World War II and Korea and the more recent conflicts in Afghanistan, Iraq really pushed military investment in terms of technologies. Prosthetic technologies had a major advance. I love the way this wounded warrior decided where he put his tat on his residual limb. And it's really pushed the envelope of the need for rehab and supporting the advances in technology. Brain injury, the signature injury from those IEDs we saw earlier, has been a way of really pushing forward the knowledge base to do things as best we can. As of 2 days ago, I have no idea what's happening anymore, whether the Affordable Care Act is going to go away. Partisan politics is driving us crazy. I spend a lot of my time in Washington trying to advocate to preserve access for the kinds of services we are capable of delivering to the people who need them, and it's all about the money. But the wounded warriors, the work that you all do in trauma, resuscitation, major laws such as the Impact Act and some other legislation are going to have a major effect on our world. Healthcare reform has been very challenging to, people want to pretend that you can do the things we do in a rehab hospital in a less expensive way, and that as long as it's cheaper, we can do it and just call it a day. And you know as well as I do that the right setting is as important as the right people for the right outcomes. So we're continuously challenged with a variety of pressures from payers that want to spend less money. My care is essential, your care is discretionary, is sort of the view of a lot of policymakers. And so we're constantly fighting over insurance coverage, design of plans, the insurance benefit for rehabilitation as part of the Essential Health Benefits Program. Post-acute care, the thing that happens after you keep somebody alive and they can not only leave the ICU but leave the hospital, where do they go next? Well, if you're really lucky, that person can go home, but a lot of the time your patients need to go someplace else, whether they come to a long-term acute care hospital that our company runs a lot of, whether they can come to a rehab hospital, and frequently you're confronted, and your discharge planners are confronted, we've got to get the bed empty, they're surviving now, get them out. The first person who says yes gets the patient, so there's almost a feeding frenzy of getting the patient to the first bed, and the first responder might not necessarily be the right responder for what the patient really needs. So we have to work our way through the mire of reimbursement and licensure status and the regulatory environments that constrain some of our abilities to say yes as quickly as people might like, and whether there's enough money to afford to deliver these highly expensive services. Those exoskeletal robotic systems, $50,000 to $90,000 a pop. A prosthesis, the electronic prostheses, the same ballpark. I told you the $470,000 of capital expense to put just one Locomat in an offering. So there's a lot of differences between settings, and you need help these days. I would not expect most of you to be able to understand the nuances of differences between a nursing home that is a rehab center because they have some therapists available versus a rehab hospital that has 12 hours of nursing care a day and 24-hour physician availability and a whole different level of services. You need to rely on experts who really do understand the nuances of differences, not just the first person that says, yeah, get your patient. You put too much time and energy into helping that patient survive to let them go just any place. So we owe you a better way of explaining the differences in the levels of care and services so you can understand the right settings and help your patients get to what they really need. You hardly ever get to see the long-term consequences of the good things that happen. You may see a patient leave in a persistent vegetative state, and if they come running in their jogging outfit to see you 6 months later, you won't even believe it was the same person because we have those kinds of outcomes, not infrequently. So all we can do in the world of rehab to close the loop and give you a sense of the incredible things you've really done for those people and the long-term results. You don't get the instant gratification. Staying alive is your gratification. We get to see them going back to their family and friends, returning to work, to school, to an active retirement, whatever the circumstances are. And we can get past this feeding frenzy of the right place and know about the different resources and the settings of care and the processes of care, and know that there's evidence. There's very compelling evidence that shows certain kinds of patients are dramatically better in rehab hospital setting than a nursing home. For some patients, it's 6 to 1, half a dozen of the others. For others, it's absolutely essential. And the rehab liaisons, the rehab docs that are available to you for your consultation services can help you sort that through. Just because a food has eggs and flour and butter and sugar doesn't mean that all with the same ingredients are the same thing. So an egg, a souffle is not the same as a pancake. So when you see a rehab center in a nursing home and say that it does everything a rehab hospital is, be a little bit suspicious about that because there's a lot of differences for the good nursing homes and the good rehab hospitals, and you want to pick the right setting for your own patients. It's all about money. I hate to say it, but it's all about money. Everybody's trying to press for less money coming out of the system. The wonderful talk we just heard about palliative care and considering end-of-life conditions and avoiding fetal treatments. A year ago, or 2 years ago, that would have been a repudiation of death panels coming in trying to kill people because we want to save money. We're really getting things mixed up, and that's not what it's all about. So we have to be very careful to control the conversation in the right way, because money is really driving the healthcare reform conversation today, and we have to do a better job of making sure it's still patient-centric. Still, it's not about the technology, it's about the dollars. You spend the right dollars at the right time, you will save money in the long term, and you'll be doing the best service for your patients and their families and the most successful consequences for the care that you have been delivering. People are skimping on their own care. People have bought under the insurance exchange high deductible narrow network insurance policies. The first $8,000, $10,000, $12,000 of healthcare costs is still coming out of their pockets. So they're still making the same decisions they did before their insurance, avoiding primary care visits, avoiding preventive care activities because they still have to decide between buying that healthcare or buying groceries. So you all are still going to have to pay for that. You're lucky because you're taking care of people who've had catastrophic injuries and they burst through their deductibles, and so they really are being covered by their insurance by the time you see them, if they are covered individuals under some either private or governmental sponsored program. So the dollars are relatively more available for a lot of your patients than for many of the others who we see. Reimbursement rates are being pressured all the time. In conclusion, the future, all that wonderful stuff that Darth Vader experienced, we'll be able to do that too if we stick together and we increasingly tie together your hyperacute world with my rehab world, with the long term, with the palliative care world, and see it as a seamless whole and argue collectively to make sure that the right things are happening for the right patients at the right time so we can advance all these technologies and do the right things for patients and make the hard work you've all done in the resuscitation and acute management have the greatest value to not only the individuals and their families but to our society as a whole. We can embrace the innovation and change and make our futures happen with a little bit of work together and a little bit of vision. So thank you very much for going back in this brief in time machine for me. And we have some time for conversation now, I think.